Thank you for joining us for this MDA Engage community webinar on the treatment landscape of SMA. With multiple therapies now in market and more continuing to be studied, it is important that you have the information you need to make the best choice on treatments for your care. My name is Michelle Barrios, and I am the Community Education Specialist at MDA. We are thrilled to have you join us today for this important and educational webinar. The webinar today is part of the larger MDA Engage flagship community event series, which focuses on bringing the neuromuscular disease community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming virtual education events. We are recording today's event and will be posting it to the mda.org website for on-demand viewing to ensure that those who were not able to join us live today are able to access this information. Please know that all phone lines have been muted. We will be having a question and answer session towards the end of the webinar. Please be sure to utilize the Q&A window to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A bubble to open the window and enter your question. You do not need to wait until the Q&A as questions come up along the webinar. Please feel free to send those in. Before we begin, I would like to say thank you to our speaker, whom you will meet shortly. I would also like to thank our event supporter, Genentech. We would not be able to provide events like this if not for their generous support. So thank you very much. The Muscular Dystrophy Association is committed to transforming the lives of people affected by muscular dystrophy, ALS, and related neuromuscular disease. We do this through innovations in care and innovations in science. MDA's reach with research is vast. MDA is the largest non-governmental funder of neuromuscular research in the country. To share a little bit specifically to MDA's work in the SMA research landscape, MDA invested more than $500,000 on SMA grants in 2019. In 2019, MDA had 14 active SMA grants. MDA invested nearly $4 million on SMA grants in the last 5 years. And since its inception, MDA has invested more than $48 million in SMA research. With that foundation, let us review the objectives for today's webinar. Attendees will review the current treatments for SMA, learn why intervention early is so critical, learn about future treatments for SMA, and discuss how to choose the right treatment for you or a loved one. Now, I would like to introduce our speaker. Dr. Shiraboga is a professor of neurology and pediatrics at Columbia University Medical Center and former interim director and program director of Division of Pediatric Neurology at Columbia University. She is also a member of the SMA Clinical Research Center of Columbia University and director of the Pediatric MDA Care Center at CUMC. Dr. Shiraboga's clinical research experience has included NIH-funded cohort studies of congenital infections and neurodevelopment disorders. Over the past 10 years, her research has focused on SMA clinical trials, including groundbreaking first in children Nusinersen clinical trials. And with that said, I would like to move the presentation over to Dr. Shiraboga.
Thank you, Michelle, for that kind introduction. And let me share my screen so we can start the presentation. Is it viewable?
Not yet.
Ah, then we have a problem. Okay.
There we go.
Okay. Very good. Let me just open this. and welcome everyone. I've titled this presentation Therapeutic Options in SMA, and now that we have options, decisions for treatment become a little more complicated. What I endeavor to do here today is to share with you the information that we've gained over the years in terms of the natural history, but especially with regards to the clinical trials. I will go a bit in depth from a molecular biology, because I do think it's important for people and families with SMA to understand what causes the disease and how the medications work and how do we decide that they are working? What are those clinical outcomes? So I hope not to use too much jargon. These are my disclosures. And I'll just briefly say my spinal muscular atrophy is a progressive recessively inherited neuromuscular disease. You're all aware of that. And it's characterized primarily by muscle weakness due to loss of spinal cord motor neurons. And those are the neurons in the spinal cord that connect to the muscles. And when they're damaged, we get weakness. And the genetic defect is a mutation in the SMN1 gene. There are three main types, and these are the phenotypes. What does that mean? The clinical expression of the disease. So there's an infant type, the type 1, which is very severe. Survival past 2 without intervention does not occur. And it's the most prevalent type. The outcomes that we look for is going to be survival, respiratory needs, and then swallowing needs, and then motor function, and eventually motor milestones if we're successful. In the middle panel, you'll see an SMA type 2 child. This child presents in infancy, is weak, but by definition is able to sit, as this little girl is able to, but she's weak and she will not walk, and her life expectancy may be shortened, but the main complication will be musculoskeletal issues, scoliosis, contractures. This is intermediate, 27%. And on the far panel, you see a little boy who has SMA type 3, the least common. And these children, by definition, walk at some point in time, though they may lose that ability. So the way we assess outcomes differs. If it's a child who's a walker, we'll use a walking test, as well as gross motor function test. For the child with SMA type 2 who doesn't walk, then we will be looking at gross motor function test, and you may hear the word Hammersmith or MFM, which are gross motor function tests, as well as arm strength and arm movement, which is the revised upper limb module. And these are just some of the ways in which we decide that treatment is effective or not. So the genetics is a defect on chromosome 5q. Why is that important? That's classic SMA. There are other types of SMA, but these clinical trials do not address that. For example, there's an X-linked SMA. These medications are only for the 5q, which is the classic SMA. This is the most common one. And it's because of this SMN1 gene mutation. It's a recessive disorder, sort of like blue eyes. You need to have one allele from each parent with the blue eyes to have the blue eyes. The same applies to the gene mutation. So what causes SMA? Well, let's understand what the SMN1 gene does. It produces SMN protein. And you can see in that graph or diagram that if you can imagine that the DNA is like the architect with the plans, and that in the middle, as you can see here, this is the mRNA. Those are the plans to make the protein. And when they're transcribing the plans, then you get this mRNA that has these 8 exons, and that makes a full protein, a full SMN protein. Now, SMN protein has many functions, but it's extremely necessary for motor neuron health, and they suffer first. And SMN stands for survival motor neuron. When you have SMA, you don't have the SMN1 gene, so it produces no SMN protein. So if we need it for survival, how is it that SMA patients survive? And that's because, as you've probably all heard, there's the second SMN2 backup gene. And although it produces largely a non-functional SMN protein, and why is it non-functional? Well, when the plans are transcribed, it's missing this exon 7. That's why it's called delta 7. And this protein is not functional. Now, when that transcription is happening, and that's called alternative splicing, and you may hear that name with regards to Nusinersen and Risdiplam, there's a little bit of SMN protein that's being made. Kind of like they skip the exon skipping and it's included. And that's the reason why, if you have more SMN2 copy numbers, your disease is less severe because you have more SMN protein. That's an inverse relationship. Now, SMN2 is the focus of RNA-based therapies. RNA because it's working on the SMN mRNA, and Nusinersen and Risdiplam both do this. They act in a very, here on exon and intron 7, very close together, but not in the exact spot. And their end result is to shunt more protein to being full-length SMN protein and less of this delta 7. More SMN protein, strength should improve. So when we talk about mechanistic strategies for treating SMA, and I heard Michelle say at the top of the presentation that we talk about other therapies that are still in the works. And I won't go too much in detail because they are not yet results to share with you, but there are SMN independent therapy, meaning it doesn't work through the SMN protein. And the ones that are most active are those with muscle, myostatin inhibitors and troponin activators, supposed to enhance muscle. Not that good as single agents, but being used in combination with SMN modifying therapies. So the SMN modifying therapies that we will talk about are the FDA approved ones. And we talked about, you remember this little figure, of the SMN2 splicing modification, alternative splicing as I shared with you, which is Nusinersen. We call it an antisense oligonucleotide, a little snippet of RNA that kind of clips to where it needs to go. And then Risdiplam. Branaplam is also a small molecule that has a similar effect, but it has not yet completed its studies. And then in the middle here, you can see this is the double helix of Watson and Crick, where the onasemnogene apoparvovec, which is the gene transfer therapy, which you may know as Zolgensma, works by introducing a human SMN gene into the body. So let's get started in describing each of these. This is just an overview of the gene transfer, all of it to make more functional SMN protein and the mRNA-based therapies. So let's talk about Nusinersen. You know it as Spinraza. This was the first of the medications that was approved. Actually, my site at Columbia had the honor of being the first to try dosing patients, children, with this agent. And that was not too long ago. That was December of 2011. And in 2016, it was approved by the FDA for use. So one thing about Nusinersen, it doesn't cross the blood-brain barrier. What does that mean? That means that if I give it IV, it won't reach the brain. It'll stay in the body and then be excreted, but it won't reach the brain. So therefore, it has to be administered intrathecally. What does that mean? Well, this is the thecal sac, and it's just the space underneath the spinal cord where the medication is injected. That's where the CSF is. When you have a lumbar puncture, we call it LP, that's where the needle is inserted to remove fluid, and then in this case, to introduce the antisense oligonucleotide. The dosing regimen is 12 milligrams. It's the same dose for everyone, neonates and adults. And it's approved for everyone as well, neonates through adulthood. And there's a loading dose, day 1, 15, 30, and 60. And then after that, every 4 months. How do we monitor Nusinersen? Well, it's a really safe medication overall, but there are some side effects. They found low platelets. What are platelets? Platelets are as if you had a tire that had been deflated and you have to plug the leak. That's what it does with blood vessels so that you don't have bleeding. There can be urine in the protein in the urine, because it's filtered through the kidney and may cause some damage to the tubules. For the most part, there is no effect on kidney function. And then we do platelets, coagulation profile, and follow the protein in the urine. Side effects, mostly inert, and the side effects are mostly related to the complication of the spinal tap. And those are post-op headaches, local pain, and there's a cumulative risk over time. So let's see what we find in development in terms of the clinical trials in infants. So this busy slide has two functions. One is to show you what motor milestone scores are, and this is a motor milestone total score. It peaks at 26, and you can see that in the bottom here, these infants who were treated symptomatically, these were babies who, many of them had G-tubes, were weak. They couldn't have pulmonary support, but some of them had some support, and they started treatment. And as you can see over time, they continued to gain. But they did not normalize because they were symptomatic and they were treated much later than these children here. So on the x-axis, which is down here, is time. On the y-axis are the results of that milestone score. And here are babies who were treated presymptomatically. That means before they have evidence of disease. And that's very important because you can see the difference in their outcome. This line here represents SMN2 3 copy numbers. And these infants reach the ceiling of this curve, which means they're walking and their development is grossly normal. Whereas those with 2 SMN2 copy numbers do very well, but they don't quite reach all of them that range. But if you look at the outcome, it's impressive. 100% survival, 92% walking with support, 88% walking independently, which is something you never see with SMA type 1 without intervention. This is a patient of mine who was treated at 3 months of age, early symptomatic because of her younger age, but she did have some dysphagia, meaning she couldn't eat. So she had a G-tube by the time she entered the study. But as you can see, she's not very happy with being with us, but she is sitting independently, making her transition from a type 1 to a type 2. And that's really striking. She also breathes without a tube, which she should have been in permanent ventilation by now. Is she perfectly normal? No, she can't walk. She's starting to bear weight, and she does have some problems with swallowing. And right there you can see they're suctioning her because she has difficulty with handling secretions. And she has some musculoskeletal issues. But this is a wonderful response compared to what had been the natural history untreated. When we talk about older children, there's a CHERISH study, and here there are 2 different outcomes. On the top panel is the Hammersmith, that gross functional motor scale that we were talking about. And 3 points is thought to be clinically meaningful. And as you can see, over time, once they finished that placebo-controlled study and they continued, there was a 4.6 improvement, meaning they gained function and they maintained it over time. On the bottom panel is the arm strength and mobility instrument called the ROLM, for Revised Upper Limb Module, and that also continued to improve over time. So this is a patient of mine, one of the earliest treated. 2 years was the earliest you could treat for late onset SMA, meaning not the infant onset, and type 1, I mean. She had lost the ability to crawl at 20 months, and 2 months into her treatment, there had been no difference. By 3 months, she was crawling on all fours, and by 4 months, she was walking with the walker. Very impressive results. I would like to report that she's walking normally now, but that early optimism did not materialize. She is walking, but with a walker, and has had some difficulty with musculoskeletal issues. The Nusinersen dose is the same for everyone, so I'm hoping that a study that will be looking at higher doses of Nusinersen may have better efficacy as children grow. So what's the real-world experience with Nusinersen? Well, the clinical trials were only children up to 9 years of age, but it does work in SMA type 3, it does work in adults. And there are a host of issues with regards to access. With infants, with children, they'll need sedation and anesthesia repeatedly until they grow old enough that they don't require that. And then as the musculoskeletal issues develop or are present, then you may not be able to access it without fluoroscopy or CT-guided foraminal injections. And then talked a little bit about the underdosing, that the dose is okay for younger infants, but for adults, they may need a higher dose. And that there may be a distribution issue where there's more that reaches the lumbar spine than reaches the bulbar spine. So let's move over to onasemnogene apoparvovec. You know it as Zolgensma. This is a AAV9 viral vector. It was approved for use in the US in May of 2019 for children under 2 years of age. And it's a one-time intravenous infusion, and you can see just how much viral vector genome they're receiving. That's 1.1 to 10 to the 14. And you can't have antibodies to it. You have to pre-treat with steroids to suppress the immune response. And you need to monitor the liver function test and troponin, which was an enzyme of the heart that we monitor also for heart attacks. It's a leakage of enzymes from the cardiac muscle. And you can't use it if the titers are high, greater than 1 in 50, or if there's a pre-existing liver problem. This is the AAV9. It's a very benign virus. It's not pathogenic per se, unless it's associated with adenovirus. And what it does is carry this precious cargo, which is human SMN DNA, and that is introduced into the nucleus. It's transcribed, and voila, you have SMN protein. Now, this is administered early on, but you cannot administer intravenously in older folk, and that's because the viral load would just be too much. But in children under 2, it's administered intravenously, and it transfects various tissues, including the heart, and this is in order of decreased order of concentration of the vector: heart, lung, liver, lumbar spinal cord, quadriceps muscle, and brain. There is a dilution effect, meaning cells that replicate tend to lose their SMN gene because they are replaced by genes that don't have the human SMN gene. But cells that don't divide, and those are neurons, and maybe myoblast, will maintain that. There is toxicity. Preclinically, they see necrosis, liver enzyme elevation, and in rare instances, liver failure, none of them permanent with recovery. And in the heart, preclinically, and this is toxic doses, not what's used clinically, there can be cardiac dilation, means swelling of the chambers, cardiac fibrosis, and clinically we follow the troponin. So far, the troponin seems to resolve over time. The first study was the START, and this shows, and I'm not going to belabor too much, this shows that at 20 months, none of them had any need for permanent ventilation, and they all survived, which they should be 8% of children in the natural history that should do that. And then This is the CHOP-10, which is that motor function that's specially designed for SMA type 1. They all are doing very well up here, except for this patient who was started late at 8 months. Shouldn't have been, because it's up to 6 months. But the clear thing was, if infants were treated with onasemnogene at a young age, less than 7 months, and the average was 3.4 months, and with early SMA disease, meaning no oxygen requirement, no swallowing difficulties, they all survived, they had no need for permanent ventilation, and they didn't develop swallowing problems. They did later studies, and these are recently completed, both in the US and in Europe, and note the young mean age, 3.7 and 4.1. And similarly, you see a very nice response, and what this shows is over time, that survival, meaning no permanent ventilation and survival, about 90% at 13.6 months. So these are very striking outcomes. And this is a patient of mine. She came to us from Poland. Her brother has SMA type 1, and you can see he's quite affected, G-tube and trach dependent and immobile. And at 18 months here, she is leaving and terminating the study to go back home. And I don't know how well this will transcribe, but you can see that she's walking independently and her development has been normal. She was slightly symptomatic. We thought we caught her pre-symptomatically, but she had lost her reflexes. And on the bottom right, you'll see that's more current, and she is actually squatting to grab some sand, which is a very normal child behavior. So what about onasemnogene pre-symptomatically? There's a study called SPRINT. It's not completed the way the nurture study is, but it also shows a very good response. And here you'll see, this is age on the X and gross motor scores. And this is the Bailey, which is a common developmental motor score that's used in all walks, not just neuromuscular. And in the gray is the normal range. And you can see the difference between 2 SMN2 copy numbers on the left and 3 SMN2 copy numbers on the right. This is very new. This was just presented at the World Muscle Society meeting in October. So again, as we saw with nurture, early treatment with SMN2 is not as good as early treatment with SMN3 copy number. And I think we will find out soon why that is. So moving along, let's talk about Risdiplam, which is the newest agent in the market. Now, Risdiplam is also an mRNA-based. You saw how it works, increasing that alternative transcription or splicing. And it is an oral medication. It's given once a day. And it has, on preclinical, that means we haven't tested it in humans, but in animal models, when you give it, you find the same concentration in the brain than you do in the blood. And as a result of that, there are theoretical advantages of the systemic effects. Nusinersen, for example, works in the central nervous system, but there's not much in the rest of the body. There's still very good results. But in very young infants who may have less SMN protein in other organs, there is a possibility that that might have an advantage. It was found to be safe. There were no of the preclinical effects that had been seen on the eye, and no one withdrew due to Risdiplam due to any adverse events. And that's not just the infant study, that's also the later onset SMA. And this medication is brand new, approved in August 2020. So the first study is the infant study. It's called Firefish. They're all called some sort of fish, don't ask me why. But this is 2 parts. The part 1, which was a dose finding, and a part 2, which was this trial proper. And after 12 months, 41% of the infants treated for 1 year, 12 months, were sitting unsupported. When you combine that with the total amount, that was over 1/3 of patients were sitting, transforming close to what would be a type 2, though not all of them were sitting independently. The secondary endpoints that I think are important is that even though they were treated much older, I think the mean age was 6 months and change, they were event-free, alive and no permanent ventilation, and that was sustained. And if they didn't have any swallowing issues, they did not lose any swallowing issues. And they improved motorically as well. The next study is in the older onset SMA, called Sunfish. Sunfish is unique in that it is the only SMA study that included adults. And it also is distinguished by including patients with more advanced disease. These are patients who had scoliosis. A majority of them did, even some severe, or who could have hardware, which is very different in terms of the pediatric studies. For example, the Nusinersen study, the oldest child was 9 years old and could not have scoliosis. And what they found was that since it is a medication that is given orally, you can obtain SMN protein levels in blood. And they found that on the bottom here, you can see that there was about almost a twofold increase in the 2 to 11 years of age and about 2.5 in the 12 to 25 years of age. The main outcome of the study, which was recently found, is their primary endpoint. Remember, we talked about gross motor function test, the Hammersmith. Well, this is the MFM. The MFM is a little different. It's more used in Europe. It includes more distal and trunk activity than the Hammersmith. And they found that there was 1.55 points difference on the MFM. Now, this may not sound like very much, but for the advanced stage of disease in these patients, the fact that they were able to show improvement is striking in my view. And if you look at those who improved 3 points, which is the clinically meaningful stage, that was about 40% of patients did. Oh, that's what we're showing here. Close to 40% showed that 3-point, and many showed at least some improvement, which, as you know, you do want to treat early, but many patients have more advanced disease, and it is encouraging to see that there's a response in that stage of disease. Let's talk about safety. Because it is an oral medication with systemic distribution, there's a little more concern about systemic issues. And one is that it can interact with substrate of mate, transporters, multi-drug and toxin extrusion. I learned this term because of this medication. It's not well known. But if you are on this medication, your pharmacist should be aware, because you shouldn't be taking medications who are metabolized via this route, because it might lead to toxic doses. So doses might need to be changed. A big contraindication is pregnancy. Do not want to expose the fetus to this medication, so every effort to prevent pregnancy should be implemented in women of childbearing age who are on Risdiplam. Breastfeeding is always a concern. You don't want to expose a baby to this medication. And then there are potential effects on male fertility. And what is this and what does it mean? Well, we don't know exactly what it means for humans, but in the rodents and monkeys study, they found that the medication affects rapidly replicating cells. Doesn't affect prepubescent boys, but males of reproductive age, it does affect sperm, because sperm has to replicate very quickly. And so they found that there was some necrosis and degeneration, and that when you stop the medication, it tended to recover. They didn't do the study to see if it recovered if you waited long enough. So there is no guarantee that you would recover 100% to where you were. Those studies are underway, and there's that recommendation that if you are concerned about conceiving a child, that you should preserve your sperm just in case. And then it is metabolized by the liver, so you may not want to start it if you have liver dysfunction. And we do want to test liver function to make sure that it is working. So, question that's always asked is, what can I expect when I start a medication? And of course, the timing of treatment affects the expected response. If you start presymptomatically, before you lose a lot of motor neurons, then you'll have a very good response, even potentially a normal development. But motor neuron loss can start prenatally, and that's probably the reason why the 2 copies, SMN2 copies, fare a little less well than the 3 copies, and why, if you are presymptomatic, you have a baby with presymptomatic and have 2 SMN2 copy numbers, treatment is emergent, and no delay should be implemented to optimize the best response. But not everybody can be identified in this fashion, only with newborn screening or with the previous sibling. Now that gynecologists are checking for carrier status in parents, they can identify prenatally. So we have data on nurture. There's a published study. I showed you a little bit of what's with Sprint, but that's preliminary. And Risdiplam has a study that's underway, but it is not completed. So if you bring your attention to this graph, you can see that there is normal development initially, and that depends when the disease starts earlier in the type 1, and it starts much later in the type 3. And then there's a rapid decline, and then there's a semi-plateau. I say semi-plateau because there is a decline. It's just much slower, and you continue to lose function. So even if you are further along, it's worthwhile to not continue to lose function and potentially gain a little function. But the response is not going to be the same if you have been in a wheelchair for 15 years as opposed to being a baby who's not developed symptoms. So these are the FDA-approved treatments: Nusinersen, Spinraza. For SMA patients of all ages and types, we talked about the intrathecal loading dose. Onasemnogene apaparvovec for SMA patients under age 2, and it's an intravenous dose over 1 hour. And then Risdiplam, which is known as Evrysdi, for SMA patients greater than 2 months of age. Why the 2 months of age? Well, the Rainbow study, which is looking at babies under 2 months of age, has not been completed, so they can't yet show that data to the FDA. So hopefully when that study is completed, it will expand its range. And it is an oral once-a-day medication. So the question of the hour, which is better for me? And I just want to preface saying that I will not provide any specific recommendations of treatment for any specific case. We're talking about generalities and theoretical situations. But let's just start looking at the age of the patient. And there are limitations as to which you can administer. Less than 2 months of age, we heard that Risdiplam is not approved, so you have Nusinersen and onasemnogene. Between 2 months of age and 2 years, Nusinersen, onasemnogene, and Risdiplam. And greater than 2 years, Nusinersen and Risdiplam. When you're looking at the factors that might play a role, of course there's parental preference, and this is a discussion. It's not the physician who decides, it's a discussion, and we help inform the parents to come to the best decision for their child. But what are points that we take into account? Access issues, sometimes if the spinal issues are severe. Contraindications, for example, we talked about the AAV9 titer for gene transfer therapy, and liver function test for gene transfer therapy and Risdiplam. And then spinal anomalies. For example, if you had spina bifida, receiving Nusinersen would not be possible. And then the risk benefit. Risk related to the treatment versus the risk of the disease that you might have. And in this situation, I may have a different opinion than my colleagues, because I do believe that if you have a very high SMN2 copy number, you may want to sustain less risk of the treatment, or at least if there are risks that may be reversible. And then evidence in advanced disease. Risdiplam has that evidence, and that's in the best controlled way. Clinically, over time, we've seen that response with Nusinersen, and my clinical practice, we've seen that even in children who are on respirators and having G-tube requirements, there are improvements there as well. They're modest, mind you, but there can be improvement. What we have not seen yet data on is with on a SMA gene, whether in advanced disease, let's say children who have reached endpoint with pulmonary or respiratory, whether that treatment can really have the same kind of robust response, or at least a response that makes it worthwhile the risk of receiving a biological agent. So to conclude, we have 3 terrific treatment options that have altered the natural history of SMA. Early treatment, early treatment, early treatment. That cannot be emphasized enough because time is motor neuron, and it can be normal with presymptomatic. And the genetic testing is important, and we need to test early so that we can start treatment early, and that if it is a type 1 with 2 copies, we need to act urgently or emergently. And then with 3 SMN2 copy numbers, we need to act as soon as possible, but there may be a little bit more time to treat before we run into trouble. So with that, I just want to acknowledge the members of the SMA Clinical Research Center and Cure SMA and the SMA Foundation, and of course the MDA, which allows us to see our patients. And with that, I conclude the presentation. Thank you for your attention.
Thank you, Dr. Shiraboga. We already have a few questions coming in. One question is, can treatments be combined?
The question is, it hasn't really been studied properly, at least not with the SMN modifying treatments. There's commonly combination when infants who have been treated with the gene transfer therapy are placed on a second agent because there was not sufficient response. You still have the gene transfer, the gene in the patient, so that could be considered combination therapy, though some might say, well, it was given long ago, but the vector is still, the SMN gene is still there. When we're talking about the combination of an SMN modifying therapy with, let's say, a muscle modifying therapy, combination therapy is the only thing that would work because those muscle agents are not standalone. They need SMN to improve that muscle, that motor neuron, in order to gain any benefit from these adjuvants. I think the big question is, can you combine 2 SMN2 splicing modulators effectively? And we really don't know. Those studies have not been done. They could prove to be synergistic, meaning you get a better response. But since they act in a similar location, they might interfere with each other. So I think you can't say categorically yes. We just need more studies in that regard.
Another question has come in. Oh, actually, a couple of questions have come in, Dr. Shiraboga. Not sure if this is too specific, but this question says, my 66-year-old wife recently had her 10th dose of Spinraza. Would she benefit from taking, I think they tried to say, a Risdi?
Okay, I said I wasn't going to answer specific questions.
Yes.
And this is very specific, but I understand the question. And what I usually tell my patients, and I think it's good advice, is that if a medication is working for you, then you should continue with the medication, because there's been no head-to-head comparison between any of these medications, right? You look at these outcome measures, but they're not comparable. It's eggs and oranges, no, apples and oranges. I've never heard that.
It's also eggs and oranges, yes.
It is? Okay, well, it came from somewhere. But they're very different. So they're different ages, they're different electromyography. So they're older, they're younger. So you can't compare them to say, oh, look at this response because of all these nuances. There would need to be specific trials that showed that they worked. However, if a medication is not working, meaning you're starting to feel decline, you still have a lot of fatigue, you're starting to have, I don't know, bulbar issues, could there be benefit of changing? And you wouldn't know until you tried, but those are instances where you say, well, it's not working anymore. But we have to preface that by saying, what is our expectation? Because depending on where we are, how severe the disease is, you may be happy with just minor improvements and not worsening. And that stabilization of disease is very important because this is a progressive disease. So we have to be mindful of that you might be happy, and that might be the best response for the stage of SMA in which you are. And I think that's the best I can say.
Thank you. Another question has come in. Will this presentation be replayed? Yes, this presentation will be uploaded to mda.org. We will send out an email to all of our registered people who registered for this webinar when this video will be uploaded. Another question, would you recommend Risdiplam in a 67-year-old with 3 SMN2 copies and severe scoliosis?
I don't want to answer any specific questions, but let's just dissect that a little bit. Risdiplam is good for advanced disease. Risdiplam is oral, so access through scoliosis spine would not be an issue. So there's nothing to say that it wouldn't be a good option. You could also give Nusinersen. That would be a good option too. With regards to efficacy, I think there's no contrasting study to say one is better than the other. But would it be a good idea? I think it would work in that setting. In the jewelfish study, I have a 60-year-old man. I'm a pediatric neurologist, but he's one of my favorite patients, he and his wife. And he was a type 3, had lost the ability to walk independently maybe 8 years before. And he was concerned about the fatigue that he was having, that decline, that losing function were just before the dose. And he decided to enroll in our jewelfish study, and we have seen benefit. So the age itself should not be a concern because adults don't change very much. There's a difference between infants and adults, but adults of 25 as opposed to an adult that's older than 60, that should not be a concern. So those criteria would be eligible for Risdiplam as well as for Nusinersen based on their age.
I think another question that was asked may have already been answered with what you just explained. Is there going to be a study release for Risdi for older SMA3 patients? Since the study information released was only to age 25, there is a large community of older SMA patients.
That's an interesting question. But one thing you should know is that it was just not SMA type 2 patients who were enrolled in the sunfish study. There were also non-ambulatory SMA type 3. So what they had in common was that they could not walk, but they were of that type of SMA type 3. So I don't think it's a valid concern to say it wasn't studied in this age group because adults are adults. It's not like you're contrasting adults to children. And I'm hoping they won't make any kind of, the insurance companies so far have been very understanding and have not made that a distinction because it would be an arbitrary distinction. An adult is an adult.
Do we have any other questions? We'll give it a second just in case. Dr. Shiraboga, I do appreciate you explaining a little bit more about male infertility in the last, with the newest approval drug for SMA. I know that a lot of our community have questions regarding that, and I don't think it was explained fully until you just explained it right now. So I appreciate that answer and your explanation.
Sure.
I don't see any more questions coming in. If you have any more questions from now until I conclude the webinar? Oh, there goes one. Are there still studies going on for Risdi?
Yes, there are. There is the jewelfish study, which I am participating, that is looking at non-naive patients, meaning most studies you cannot have been on any medication before you enroll because you're trying to assess the effect of that medication that's being studied. But this is a bit novel in that sense. You could have been receiving Nusinersen, you could have received on SMA Gene, and then decide you want to start Risdiplam and enroll in this study. And we have 173, 78, a lot of patients that are being followed worldwide to see the response of having had that exposure beforehand. And it's more to see safety and rather than efficacy, but we will have those data points eventually.
Thank you. I don't see any more questions coming in, so we will conclude the question and answer portion of this presentation.
Michelle, before we do so, the other study I omitted was the rainbow fish, and that's the presymptomatic study that's still underway. The firefish and sunfish, infant and older onset, are still under study, and we do the extension to see how the response is over time. So they're all still underway, but the jewelfish is one that I didn't talk about specifically.
Thank you. Before we wrap up, I wanted to make sure, I have one more question coming in. So before I go to the next slide, let's see. With regard to Risdiplam and male infertility, how long would drugs stay in system if paused?
Well, the recommendation, let's take for women of reproductive age. The recommendation is to stop 1 month before you plan to conceive to make sure that all the effects are out of the body. Medication has left perhaps even before that, but any residual effects for the most part have resolved. I think that with the male fertility, with spermatogenesis, it might take a little longer to recover that function. And that's what the studies are hoping to determine what time frame that is.
Thank you. Before we wrap up, I wanted to make sure that everyone was aware that we will have more presentations around a variety of topics specific to SMA during our MDA Engage SMA Symposium taking place on Saturday, November 14th. Dr. Marcia Falker from Riley Children's Health is our event chair. This will be a virtual event as well, and I would encourage you to visit the website below for details and to register. I would like to thank our webinar supporter, Genentech. I would also like to thank Dr. Shiraboga for your expertise and knowledge in the SMA community and all of your knowledge and expertise that you shared with us today. If anyone has any questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. This concludes today's MDA Engage webinar, The Treatment Landscape for SMA. Thank you very much for attending and have a great rest of your day.